Thank you so much to everybody for joining us today on the PCFA vodcast. Today, we're going to explore cutting-edge technology of prostate cancer research and look at how prostate-specific membrane antigen, PSMA, targeted therapies are allowing us to use and see and treat prostate cancers that are spread throughout the body. To help us illuminate this fascinating topic, I am joined by two remarkable clinicians, Associate Professor Stereonostics Lee, who is the president of the Association of Nuclear Medicine Specialists and also a nuclear medicine physicist at the Austin. Also, I want to welcome Professor Nat Lenzo, the Group Clinical Director of Stereonostics and Nuclear Medicine Physician at Genesis Care. Stereonostics, I hear that you've got a presentation for us, so welcome up, and we really enjoy this presentation. I'm very much looking forward to hearing what you've got to say.
Thank you very much for that introduction, Matt. And good evening, everyone. We'll be talking about the potentials of PSMA and what nuclear medicine has in store for PSMA in prostate cancer. As you all know, prostate cancer is the second most commonly diagnosed cancer in Australian men, even overtaking that of breast cancer in 2022. It is also the second most common cause of cancer-related deaths in Australian males. In 2022, only with lung cancer being more morbid than prostate cancer. However, this rate of age-standardized mortality is expected to decrease slightly with better staging. Now, the ways to actually diagnose prostate cancer usually follows a pathway something like this, where a blood test called a prostate-specific antigen or PSA blood test is performed, and this is a protein in the blood that is detected, and a higher than normal PSA level can indicate prostate cancer, but not necessarily the case because there are other prostate conditions that can also cause a rise in the PSA levels. Part of the process is to go through a digital rectal examination where a doctor can feel the shape and size of the prostate gland. And that is usually followed by magnetic resonance imaging or MRI scan of the pelvis. And that is basically lying in a tunnel that can actually look at the signals coming from the prostate to see which part of the prostate actually has abnormalities that might indicate cancer. But ultimately, a biopsy is the only way to definitively diagnose prostate cancer. And that is, of course, with a needle that is put into the prostate to sample various aspects of the prostate gland. But now we have PSMA, or prostate-specific membrane antigen, that is located on the cells itself. It's a cell surface enzyme that is internalized, and it has been shown to be more highly expressed in high-grade tumors, metastatic disease, hormone refractory prostate cancer, and also known to be more associated with invasiveness, and you can actually target it with other types of anti-PSMA antibodies. But PSMA can be labeled with a type of nuclear medicine or a radionuclide for like gallium-68 for the imaging of prostate cancer, which is increased, which demonstrates increased PSMA expression. And what we did find in Australia, a prospective study of over 400 patients looking at this gallium PSMA PET scan, looking at the management impact of this in patients with intermediate and high-risk disease in the staging and the restaging categories, there was an overall 52% change in management, 20% in those with primary staging and 62% in those who presented for restaging. And because 30% of men had disease identified outside the prostate on this staging PSMA PET scan. And so it comes down to what can we use PSMA PET scan for. We talked about the commonly used MRI, and then of course now with the gallium PSMA. With MRI, there is a score that can be given to a particular MRI scan, and a score of 4 or 5 actually warrants signals a very highly or very high clinically significant cancer is present within the prostate gland. And there are two huge trials that were performed called the Precision and the Promise trials, which basically looked at the impact of MRI scans. And one of the questions that actually came out of it was that the Precision study did say that there were many biopsies who went through MRI triaging that still were negative. So is there a way that we can safely reduce biopsies in the future so that we're only biopsying those men who have significant malignancy? So in Australia, there was this a trial called the Primary Imaging Trial. It is a prospective multi-center study of over 200 almost 300 men actually, and the main reason to actually do this trial was to see if PSMA PET scan combined with MRI can better diagnose patients with clinically significant prostate cancer. And basically, these men had a recent MRI combined with a biopsy as planned based on the clinical risk and MRI result, and a PSMA PET scan was also performed on these patients. There was the significant findings from this is that the advantage of PSMA in men with negative or equivocal MRI, that was those with PIRATES 2 or 3, this study has the potential to reduce biopsy, with the biggest advantage being in men with negative or equivocal MRI scans, those with PIRATES 2 or 3. And the certainty of castrate-sensitive prostate cancer was found in certain characteristics of the MRI positive scans and certain PSMA PET scan characteristics with 100% certainty in particular populations. So the Primary 2 study is now underway, which is a prospective multi-center randomized phase 3 study to look at the addition of PSMA PET to standard of care biopsies to detect castrate-sensitive prostate cancer. And in this particular study would therefore look at the potential for diagnosis of prostate cancer in conjunction with MRI to better triage men requiring biopsy. And these patients are basically randomized to either standard of care prostate biopsy or they have a PSMA PET scan to be able to target the biopsy itself. Or for those who have a normal scan, no biopsy is actually performed and the patients are followed up very closely afterwards. And this really would see if there is any benefits for their health, economic, and patient outcomes. Moving on now to gallium PSMA in initial staging. And this was one of the big trials, again, that was done right here in Australia called the ProPSA Study. It's a diagnostic phase 3 randomized study of, again, about 300 patients in 10 sites across Australia, randomized to the standard of care staging of a CT scan and a bone scan, compared to PSMA PET scan, and they then crossed over to actually receive both scans. What it actually showed was that there was a superior accuracy of the PSMA PET scan of 92% versus 65% that was in conventional imaging, with a greater treatment impact of 28% compared to 15%, and fewer uncertain results like 7% compared to 23%. And really, the other findings were that of less exposure to radiation, better agreement between reporters, and there were no adverse effects seen. So what is a PSMA PET scan? Well, that's where patients get injected with a small amount of gallium PSMA, and following that injection, they wait about an hour and they go through a small tunnel like this called a PET scanner. which images the cancer cells, produces an image like down here, and then they were followed for 6 months in this particular study. And this was really the basis of the funding for PSMA PET scans in Australia, because this supported the use of PSMA PET as a replacement to the standard of care CT and bone scans. These are just some examples now of a PSMA PET scan in a patient, in this particular 61-year-old man with high-risk prostate cancer, and it only showed localized disease within the prostate gland without distant metastatic disease, and he went on to have radical prostatectomy. As opposed to this other patient, he's 81 years old, again with high-risk prostate cancer, and he had a staging PSMA PET scan prior to radiotherapy of the prostate bed. But as you can see, there are multiple black spots all over the place here, which basically correspond to bone lesions, and unfortunately some nodes as well, that he therefore was not suitable for radiotherapy alone. Other applications of PSMA PET in the restaging of recurrence post-prostatectomy, it has shown that it's been it's very good for detection of recurrent disease outside the prostate gland, pre-salvage radiotherapy, but also large studies have looked at over 1,000 patients cumulatively to show that the higher the PSA level, the higher the detection rate of PSMA PET scans. This is an example now of a 70-year-old man with prostate cancer previously treated with radical prostatectomy and followed with radiotherapy for a biochemical response. Again, his PSA went up, and initially was thought that he only had isolated metastasis that could have benefited from radiotherapy, but this shows multiple metastases, as you can see, throughout his body, and he was not suitable for radiotherapy. In another man here who had prostatectomy and radiotherapy, but despite having had radiotherapy to the rib and also the pelvis, unfortunately, there was new metastases that was found, and this time in the thigh bone, in the femur, outside the radiation therapy field, that he was then suitable to receive more radiotherapy for. So gallium PSMA PET scans in prostate cancer really can be used in different areas. Those with the elevated PSA levels, also for initial staging, for lymph node and distant metastases, and for the detection of recurrence after initial therapy, particularly in the setting of a raised PSA level, and for therapy monitoring as well. But nowadays, a new field called Stereonostics uses PSMA PET scans to adequately select patients suitable for radionuclide therapy and follow-up. What is Stereonostics? It is something that it's actually a word that's coined from two words of therapy and diagnostics. And it's like what Matt has said, it's where you see it on a PSMA PET scan, and then you treat it with lutetium PSMA, which is basically the PSMA labeled with a different form of radionuclide that is able to get into the tumors that are expressing the PSMA, like in the vertebra and the rib, as you can see here. And basically, we can actually scan them afterwards as well to see that it has gone into those areas of interest. And to illustrate this a little bit further, it is really what they call a lock and key mechanism, and it is a form of personalized medicine, making sure that we are providing the right treatment for the right patient at the right time. The key consists of the radionuclide, for example, in this case here is the lutetium PSMA, linked with the ligand, and here the ligand is PSMA, but it can be other types of antibodies or other peptides as well, or other proteins. And the lock that it goes into, it can be the PSMA receptors or other form of receptors for other types of cancers. So it is actually quite a unique form of personalized medicine. And In terms of this PSMA-based therapy for metastatic castrate-resistant prostate cancer using lutetium PSMA, the important steps is using a PSMA PET scan to select appropriate patients and monitor for treatment response. It can also be effective in end-stage disease, even as a last-line therapy, with significant improvement of clinical symptoms and Karnofsky status, with prolonged progression-free survival, and most importantly is the excellent tolerability in nearly all patients treated with no or minimal blood toxicity, as you would normally see in chemotherapy patients, and no kidney problems or severe salivary gland toxicity either. And this has been found through a couple of landmark clinical trials of lutetium PSMA in prostate cancer globally. So this was seen in a couple of landmark trials for lutetium PSMA in prostate cancer globally. And these are two of those trials. It's called the Therapy clinical trial and the Vision clinical trial. These two trials were both reported in 2021. And the Therapy trial was actually performed right here in Australia again. It's a phase 2 trial looking at lutetium PSMA compared to cabazitaxel chemotherapy, as opposed to the Vision clinical trial that was performed in the US and Europe, which is a phase 3 trial looking at lutetium PSMA and standard of care compared to standard of care alone. And it is actually based on these two trials where there is a lutetium PSMA funding application currently in MSAC for consideration, and we're awaiting the results of that. I'll talk a bit about the Australian trial because it was really the strength of a collaboration between nuclear medicine as well as oncologists and radiation oncologists, cancer collaborative groups such as ANZUP, and also NHMRC and the Australian Radiopharmaceutical Trials Network, all the way across Australia, as you can see in this map here. It was the first randomized trial of lutetium PSMA versus cabazitaxel, and the primary endpoint of PSA reduction was significant for lutetium PSMA at 66% compared to 37% for cabazitaxel. But importantly, the progression-free survival, the objective response rate, and the troublesome adverse events was also all favorable for lutetium PSMA compared to cabazitaxel chemotherapy, which is obviously a lot more toxic with greater adverse patient-reported outcomes like diarrhea, fatigue, and hair loss, amongst others. And as far as the Vision study that was performed overseas, the primary endpoints of radiologic progression-free survival and overall survival were also favorable for those patients who had lutetium PSMA compared to standard of care alone. But most importantly is that the health-related quality of life and pain and safety outcomes were also favorable for those patients that received lutetium PSMA treatment. As you can see here, time to significant decrease in function was 9.7 months compared to 2.4 months, and time to significant pain and scores was also improved at 14.3 months compared to 3 months for standard of care. And time to first skeletal event, symptomatic skeletal event, was also favorable, almost twice as long in those with lutetium PSMA treatment compared to standard of care alone. So based on these findings here, it really comes to us to start finding a role for lutetium PSMA treatment in this evolving treatment landscape of prostate cancer, which starts obviously with the local therapy for more localized disease with or without androgen deprivation therapy. And then as they become castrate resistant, you get into chemotherapy and then the post-chemotherapy. The two studies that I've spoken of thus far have really looked at this chemotherapy, post-chemotherapy space here. but certainly it's time for us to actually look to see where it might actually be able to fit in somewhere along this landscape. And this is just a quick sample of some of the trials that are already in the field, I guess, looking at where the lutetium PSMA treatment can be used either alone or in combination with other treatments. And I will now hand over to Professor Nat Lenzo to talk about one of these trials for us. Thank you.
Professor Lenzo, I mean, I think the PSMA is clearly a significant milestone for prostate cancer. So thank you for that, Seating. And it's also fantastic to see Australia and the experts that we have in Australia collaborating to take our research onto a global stage. It's truly exciting. And yes, please, Nat, we'd love to hear more about the prostate therapeutic program. And so with that, I'll hand over to you. Well, that was a fantastic presentation. Thank you.
Thanks, Seating. Thanks, Matt. So thanks for that. It is a really exciting time in nuclear medicine and in prostate cancer therapy globally. I'm going to talk about some of the programs that Telix Pharmaceuticals are involved in. That's the prostate trials. But as Seating said, there's multiple different trials from a number of different companies looking at not only lutetium PSMA, but alpha emitters and all sorts of different ways of attacking this problem. And I think some of the areas that are really quite exciting are the combination therapies. And so I think it's a good time to be in this field, and it's a good time for patients. These are my disclosures. So what I'm going to talk about is Latissim Telex591. It's a bit different to the lutetium PSMA that was used in the therapy and also in the VISION trial. Those were small molecules or peptides. And this is an antibody. And one of the nice things about antibodies are that they bind incredibly well to their target. Their binding is much higher and your internalization rate is much higher. So you should be able to get more therapy to the cancer. This is not a new antibody. It's been around for a number of years. And there's now been over 200 patients who've actually been involved in phase 1 or phase 2 trials using this antibody. So we have a fair amount of data on this antibody. If we look at the biodistribution, and that means where the agent goes, it's quite different to what we see with the peptide or the small molecules. So what was used in the therapy trial and in the VISION trial was a small molecule known as lutetium PSMA 617. And it binds not only to the tumor, but also to salivary glands, lacrimal glands. There's a bit of hepatic binding, a fair amount of splenic binding. It's excreted in the kidneys, and there's a bit of small bowel binding. So you'll see the kidneys light up, you'll see the bladder light up. The antibody is very different. You'll see no activity in the salivary glands, none in the lacrimal glands. It is hepatically cleared, so the liver clears it, so you'll see this activity there. You'll see some in the bowel because it's excreted in the bowel, but virtually nothing in the kidneys or in the bladder. So a very different appearance, and that means it has some unique potential advantages. You won't get the potential toxicity to the salivary glands. If someone has problems with their kidneys, that's less of an issue with the antibody. So it is a very interesting and a different type of targeting moiety. Also, because it's an antibody and it circulates for prolonged periods of time, and I'll show you some images of that with the next few slides, it means that occasionally when we don't see a lot of PSMA expression with a peptide that it gets administered and binds relatively quickly and clears quickly, we may not get enough dose that we would like to the tumor. Whereas with an antibody, which will circulate for over a week, continually binding. And then there is a thought that over time, we may get enough dose to have a therapeutic effect, which we may not see with the peptide. And of course, if you have high tumor burden, then we should see quite exquisite uptake. And that is also evident in the images that I'll show in the next few slides. It's also given in a very different way. So when we give the peptide, it's usually given every 6 to 8 weeks, and at least 6 doses of the peptide are given. With this agent, because it has such a long circulating half-life, we actually give it in 2 injections in the first 2 weeks, and it has an effect that lasts quite a period of time. So you give less lutetium overall, and you give it up front, and then you don't really need any treatment for a longer period of time than what we used to with the peptide. So Telix have got 3 programs on, and I'm lucky enough to be involved in all 3. So the Prostate Select, we've just completed 30 patients, and we'll be reporting our data later this year. But this was really an early phase 1 trial just to have a look at the characteristics of this agent and work out the right dosing to use for future trials, and to make sure that it was safe and in our hands. And in fact, even though it hasn't read out completely, there were no issues involved at all in that trial of 30 patients. The prostate target, we've just started accumulating patients or recruiting patients, and that's a very interesting trial because this is looking at early disease now. So an early recurrence using a combination of radiotherapy, which is standard often with the small volume early recurrence, but now adding this antibody to try and prolong the state of remission. So this is a new and exciting approach of combining radiotherapy with the radioligand systemic therapy. And then finally, the Prostate Global trial, which in fact opened today. And this is a trial of using the antibody Telix591, lutetium Telix591, with standard of care, compared with standard of care. And the standard of care will be novel anti-androgen drugs or docetaxel chemotherapy. And this is a global study which will recruit almost 400 patients around the globe. And it's great that it's starting in Australia. So this is from the Prostate Select trial. The image that on your left is the gallium PSMA image. And you'll see over time as we image the lutetium Telix591, there's slow accumulation over days of the agent as it binds more and more and more to the tumor, which is very different to what we see with the peptide. And as I've said, we've now completed that trial, and we should be reading out that trial by the end of the year. So as Ziting showed, this is a similar picture showing the sort of natural history of what happens with prostate cancer with initial localized therapy. And then as you have a recurrence, other treatment combinations. And you'll see that a number of companies here, I've just listed Novartis and Telix, where they are starting to do their trials and look at the whole continuum now of where we can use these agents from early disease all the way up to end-stage disease. So as I mentioned, the Prostate Global, this is the phase 2/3 study. It's a 2-to-1 randomization. So 1/3 of the patients will just receive standard of care, and 2/3 will go on to lutetium Telix591 plus standard of care. The standard of care, as I've mentioned, could be a novel anti-androgen drug, or it could be docetaxel chemotherapy. So that really makes it very, very useful, because that is really how we manage these patients who have got advanced disease. And this is an advanced disease study. The other beauty of this trial is that it's a crossover trial, so that if you progress on your standard of care, you can cross over and obtain lutetium Telix591, which is also something that I think is very useful for our patients. There's a whole lot of eligibility and inclusion, exclusion criteria. These are fairly standard for these types of trials. But by and large, this, I think, will be a very useful trial to give us a very good understanding of how this agent, in combination with either novel anti-androgen drugs like enzalutamide or abiraterone, or chemotherapy in the form of docetaxel, actually can make an impact in end-stage disease. So on that, I'll end up saying it's an exciting time. Telix have invested in a number of trials which span early to end-stage disease, and I'm very thankful to be part of that program.
Thank you so much. Now, I mean, that's really exciting, again, to see such advances in prostate cancer, which, as we know, has just taken over breast cancer as Australia's most commonly diagnosed cancer. So this is a huge unmet need. I might just ask a question, if I may, and then I'm going to see things quickly. And it's generally, Nat, about patients on clinical trials and how they ask, you know, what advice, I suppose, would you give to patients or carers who are listening about asking their healthcare teams what trials are available? Because often patients feel, you know, inhibited a little bit about asking, you know, if there are other options within the clinical trial space.
Yeah, look, and that's a very good question, Matt. We always try to put patients on trials, and there's been very good data showing that patients who do go on trials often have better outcomes. They're carefully monitored. They get access to the latest agents. There are no such things now as placebo-controlled trials, which a number of patients always worry about. We don't do placebo-controlled trials in cancer. So everyone is either on standard of care or, and like the Prostate Global, if you're on standard care, you will cross over to the new therapeutic agent if you progress on standard of care. So the best ways are, there's a number of different ways of doing it. Genesis Care, for instance, if you go to our website, we listed all the trials that we are involved with. Clinicaltrials.gov is a website that also lists trials. Most of the oncologists have their own either apps or their own access to different trials, and we encourage patients to ask their oncologists about the different trials, or to search, particularly under clinicaltrials.gov. That's a reputable site, and you know you're getting reputable studies on that site.
Thank you. That's such a great answer. I know many patients are really asking a lot of questions about how they can actually access all this information. So thank you. And Ziting, I know you did cover this in your presentation, but a lot of patients are sort of hearing PSA and then they're hearing PSMA and they're getting a little bit confused. I know you covered it, but just to recap, could you just quickly just explain the differences between the two?
Thanks, Matt. So PSA really is a blood test. So as any other blood test, doesn't need fasting, and you know, just go there, have the test, and there's a normal range and then a normal range. Whereas a PSMA test, or PSMA, is a scan, is a PET scan, and it involves the injection of a small amount of radioactivity into the patient. After a short period of resting, they go into a scanner to actually have the scan done, which then detects where the PSMA has gone to. I would actually like to say that it's quite different to an MRI scan as well, because MRIs do tend to be quite claustrophobic, because the hole or the tunnel is actually completely enclosed, and therefore you can actually feel claustrophobic in it, as opposed to a PSMA PET scan, or PET scanners are somewhat more open and definitely less claustrophobic to patients.
I'm sure that's very reassuring to many patients who do, you know, have that anxiety, and we need to reaffirm that this is very different to traditional scans, and particularly old scans. So thank you so much. So thank you both for taking the time to share more about nuclear medicine. It's incredibly fascinating. It's going to be a very popular topic. Just before we go, though, I was wondering, could you end with both of you, each of you, sharing just one take-home message that you'd like to leave with our viewers today? Maybe we'll go to Nat first, and then Ziting.
One take-home message. Well, I think take-home message is that Australia is very good at doing clinical trials, and we have some fantastic clinical trials in this space, in the theranostic space in prostate cancer. And I would urge you to talk about it with your doctors, your oncologists, your radiation oncologists, and to try and find if there is a trial that can suit you.
And I guess my take-home message would be, it is a very exciting time, I think, for men with prostate cancer. It's not as much of a death sentence as it used to be. There are a lot of options out there now, and definitely when you do see your doctors, to speak to them about what is available, both in trials, out of trials, the internet is a very handy tool these days, and the pcfa.org website actually does have a lot of very useful information as well.
Thank you so much. Great segue, and thank you so much. This has been a truly brilliant discussion. We're really incredibly grateful to the both of you, everybody, for joining today. Please do like, share, comment, pass this on, get the word out. If anyone's watching has questions, just get in touch with the PCFA by calling 1-800-220099 or by emailing telenearth@pcfa.org.au. Thank you so much. Thank you to the major partners, Telix Pharmaceuticals, MedWise Consulting. A reminder that people can call 1-800-220-99 for information or advice, or go to the website www.pcfa.org.au to learn more. And we'll see you next time. Thank you again.